Good afternoon. I'd like to thank the organizers of this virtual conference for the kind invitation to speak today. I hope everyone listening will gain some new piece of information from this talk, if not several. My name is Dr. Michael Hall, and I'm a gastrointestinal oncologist and clinical cancer genetics expert at Fox Chase Cancer Center in Philadelphia. At Fox Chase, I'm fortunate to lead a small but mighty department of 4 MDs, 5 genetic counselors, 2 advanced practitioners, and clinical research and support staff. Today, I'll mostly be wearing my GI oncologist hat to talk about what's new in colorectal cancer treatment, a 2021 update. As a reminder of colorectal cancer incidence and mortality in the United States, many people don't realize we have seen real and measurable declines in colorectal cancer incidence and mortality since the 1970s, with a 55% decline in the death rate since 1970. This can almost entirely be attributed to greater awareness and screening for colorectal cancer in this country, primarily performed by colonoscopy. However, interestingly, there's also been a 2% increased incidence in colorectal cancer in the under 50 population since 2012. Some data actually even suggest that this started even earlier. Survival from colorectal cancer greatly depends on the stage at diagnosis, and non-white patients are still diagnosed later than white patients. A big part of this is attributable to stage at diagnosis. Underserved and Black Americans especially tend to be diagnosed at more advanced stages of colorectal cancer, where cure is less likely. Overall, thankfully, well over half of patients will be diagnosed with early and/or curable disease, but a remaining 15 to 20% will have metastatic disease at diagnosis, which makes cure much more difficult and survival much shorter. Around 40% of patients are diagnosed at early stage, where the 5-year survival is 90%. With locally advanced stage, we know we have about a 70% 5-year survival, but when patients are diagnosed with metastatic cancer, there's only about a 14 to 20% 5-year survival. And of course, when we drill down to disparities in stage of diagnosis, we quickly find that poorer, underinsured, and less educated patients, as well as Asian, Black, and Latinx patients compared to white patients, but that there is also a geographic component to disparities where living in the South and Central US is associated with screening rates 10 to 15% lower than on the coasts. So while we've made a lot of progress in decreasing incidence and mortality from colorectal cancer in the past 40 years, there's still a long way to go. So let's switch gears and talk a little bit about new molecular technologies in the management of colorectal cancer. Circulating tumor DNA, also known as ctDNA, has become a new and exciting modality in the treatment of colorectal cancer. What's exciting about this is that this technology now allows for very small amounts of circulating tumor cell DNA, which is free floating in the blood, to be detected and separated from a standard blood sample. And with that sample, we can do many incredibly valuable things in the diagnosis and treatment of colon cancer. We can use the information from this DNA to understand whether a tumor has particular targets that we may want to use for treatment, but without having to put the patient through an invasive biopsy. So this is especially useful for patients who can't have a biopsy. On the same vein, circulating tumor DNA can also be used to monitor a patient for emergence of resistance mutations to therapy, allowing early progression to be detected earlier and therapies changed, and most importantly, unneeded side effects to be avoided or minimized. Third, circulating tumor DNA can also help us prognosticate patients who have had a surgical resection, but whom we are unsure whether they would benefit from adjuvant therapy with chemotherapy. Several studies are ongoing nationwide and worldwide looking at the power of circulating tumor DNA to help doctors know whether they should give adjuvant chemotherapy to a patient, particularly a low risk stage 3 or stage 2 patient, or whether they can forego this. Finally, circulating tumor DNA can also be used to detect cancer in seemingly healthy individuals. New platforms have shown their ability to detect pre-symptomatic tumors and even distinguish the tumor types in patients where we actually would otherwise have no idea that there was a cancer hiding or brewing. So this could really be revolutionary in reducing the screening burden in the population from things like mammogram and colonoscopy, as well as to aid us in the diagnosis of rare or occult tumors for which we currently don't even screen patients. Finally, we've seen some pretty magnificent advancements in recent years following the advent and widespread uptake of next-generation DNA sequencing in the hereditary testing for cancer risk, as well as tumor testing. In the germline setting, NGS has allowed more cost-efficient, rapid, and wide-scale germline testing using panel-based next-generation sequencing technologies, rather than having to test every gene sequentially, which was really where we were even up to about 5 or 6 years ago. While this approach has increased the comprehensiveness of the testing we're able to offer patients, it's also added complexity to the process of counseling and to the interpretation of results, especially the much larger number of uncertain results that can be found when testing in this way, particularly in minority patients who have just generally had less genetic testing done than Caucasian populations. A large study led by Jules Sameter at the Mayo Clinic, published recently in JAMA Oncology and referenced here in the upper right, found that among all comers with colorectal cancer, there was roughly about a 15% germline mutation rate finding. This correlates closely with results from Sophia Stadler and her colleagues from Memorial Sloan Kettering, who performed matched tumor normal testing, again, using next generation sequencing technologies on tumors in a blood sample. And again, in their colon cancer population, found very similar results, about 15 patients with actionable germline findings relevant to perhaps both the patient and their family members. So now let's move from colorectal cancer diagnostics to treatment. One treatment advance I wanted to bring up was the increasing use of minimally invasive surgeries in the management of colon cancer and rectal cancer. While what I show here, which is called TAMIS surgeries, have been around for a while, there are increasingly more providers with skills in this arena. These surgeries can be especially useful in patients with superficial lesions in the rectum, where a more extensive rectal surgery is not preferred due to poor health of the patient or comorbidities, or perhaps due to the proximity of the lesion to the anal sphincter or other structures. One limitation of this approach is that, unlike a low anterior resection, which is the standard of care surgery, which would remove part of the rectum and surrounding tissue, including lymph nodes, in a TAMIS surgery, there's no lymph node harvest at the time of surgery because this is a superficial surgery. So ultrasound and MRI are used to help evaluate lymph nodes in the area. But of course, these are imperfect, so there is a risk of nodal relapse in patients who undergo this surgery. Many new studies have also come along in the perioperative setting for more advanced rectal cancers. And this has really sort of changed the landscape of how we're treating rectal cancers in the last few years, because the way we'd been treating them for many years before had always really been the same way. So for many years, rectal cancer for stage 2 and 3 disease was always treated, as I said, the same way: chemoradiation for 5.5 to 6 weeks, followed by a surgery, followed by adjuvant chemotherapy. But 3 trials in the last few years have examined different approaches to delivering chemotherapy and chemoradiation. In the Rapido trial, which I have here at the left, all chemo and radiation were given before surgery, with radiation given rapidly right at the start, which can be particularly helpful in patients that are quite symptomatic. So this approach is one version of an approach that's increasingly called TNT, or total neoadjuvant therapy. In the OPRA trial, TNT was also used, but with a slightly different approach. The goal in the OPRA trial It actually started in one arm with the chemoradiation followed by chemo, again, all given before surgery. The second arm was chemotherapy followed by chemoradiation, all before surgery. But actually the goal was actually not to have surgery for some patients, but to see how many patients in each of these arms were having a complete response to the therapy and could potentially avoid a surgery, with data over the past several years showing that patients who have complete responses may be able to avoid surgery. So this, this was particularly important for patients who have tumors that are very low in the rectum that put the rectum at risk, or put the anus at risk, I meant to say, and where an approach where we may be able to avoid a surgery may be the approach that is most attractive. Finally, in the PRODIGE study, the dial on neoadjuvant therapy was sort of turned up even higher than it's been in the last few years. So these patients started their chemotherapy not with 2 drugs, but with a 3-drug regimen of FOLFIRINOX, which is not a regimen that we sort of right now typically use in rectal cancer. So the goal of this was to give even more chemotherapy upfront to perhaps shrink tumors more and reduce the risk of distal relapse even more with intensive chemotherapy upfront. They then underwent surgery after that intensive chemo and then some additional less intensive chemo afterwards. So this was not a TNT approach, but was just, again, an approach meant to provide more intensive chemotherapy immediately to these patients. Another landmark chemotherapy study in the past few years has been this study called IDEA. Here, the study team examined whether in the adjuvant setting, after resection of a stage 3 colorectal cancer, 3 months of chemotherapy, which was up until recently not considered standard of care, would be equivalent or non-inferior to 6 months, which has been the standard of care for many years now. So what this investigative team found was that in those patients with low risk stage 3 colorectal cancers, that being N1 disease of stage 3 colorectal cancer, 3 months of either FOLFOX or CAPEOX chemotherapy were acceptable and non-inferior to 6 months. And actually the CAPEOX data edged out the FOLFOX data as being even a little bit better. But in the high-risk setting, 3 months of FOLFOX was clearly inferior to 6 months of FOLFOX, while 3 months of CAPEOX was still non-inferior to 6 months. So this kind of really changed the landscape of how we think about the duration of chemotherapy. I think a couple things this trial did. First of all, I think now in patients who are able to tolerate it and are willing, I think there's a sense that CAPEOX therapy is actually perhaps a little bit better than FOLFOX. And certainly in higher risk disease, you would not consider that 3 months of therapy with FOLFOX. You would only consider potentially 3 months of therapy with CAPEOX. Now, it's not 100% clear to me how many docs are actually doing that. Currently in my practice, I use the 3 months of CAPEOX in the low risk setting, and I still give, or generally still give 6 months of therapy in the high risk setting. But I think, again, practice patterns are evolving with time. Okay, so now let's wrap up with new approaches to management of advanced disease. So let's flash back again to our discussion of diagnostics. The standard molecular diagnostic evaluation for colon cancer has really changed a lot in recent years and now includes mismatch repair or MSI testing and tumor mutational burden testing to determine eligibility for immunotherapy, RAS and BRAF testing to determine eligibility for anti-EGFR therapy or the Beacon regimen, which I'll talk about in a minute. HER2 testing to determine eligibility for anti-HER2 therapy, which again has also come about as a treatment approach in about 6 to 10% of colorectal cancers. NTRK fusion testing to determine use of NTRK inhibitors, which again are rare, but maybe 1% of colon cancers may have these NTRK fusions. And then, if a clinical trial is being considered, other targets like MET or MET amplification, BRCA1/2, ATM, and other targets are assessed on these large next generation sequencing panels, which I kind of discussed earlier, and are also evaluated. Several important studies have come along in recent years demonstrating that immunotherapy is highly effective in the treatment of MSI-high colorectal cancers and across really any tumor type that's MSI-high and all the GI cancers that are MSI-high. So for colorectal cancer, about 15% of cancers overall will be MSI-high, but these are kind of dominated by earlier stage cancers because only about 5% of metastatic colorectal cancers will be MSI-high. Recently just reported this past year, the Keynote 177 trial on the left showed that for MSI-high colorectal cancer, a substantial number of patients will achieve long-term disease stability and should be receiving immunotherapy upfront. And I think this is really important. It's not everyone though. And I think if you look at this picture in the lower left here, you see that for a short while, chemotherapy actually did better. And that's probably for those patients who have very aggressive disease, because immunotherapy does take some time to really sort of pick up speed and start controlling tumors. So for very aggressive disease, I do not argue with doctors who still use chemotherapy in that setting. But for slower growing or smoldering disease, I think these data clearly show that starting with immunotherapy is the best approach. Another trial, Checkmate 142, which I show here on the right, also looked at dual agent immunotherapy in the frontline setting. And of course, there's been several trials that have looked at single and dual agent therapy in the later settings or advanced, heavily pretreated setting of colorectal cancer now. Again, this Checkmate 142 trial showed, excuse me, perhaps slightly better response rate with dual agent therapy in the frontline setting, but this has not been FDA approved yet. So still, frontline setting is single agent therapy for patients who have MSI-high colorectal cancer. As I alluded to a moment ago, Scott Kopetz and his team from MD Anderson Cancer Center have really been leaders and working hard to develop multi-agent targeted therapy regimens for BRAF V600E mutated colon cancers, which represent about 5 to 10% of colon cancers overall, and are generally considered by doctors to be some of the most aggressively behaving colon cancers. So what this team has been able to show really through some incredible research and breakthrough use of dual or triple agent blockade, they've shown that using an EGFR inhibitor like cetuximab or panitumumab plus a BRAF inhibitor can work together to dually block the RAS pathway and really lead to doubling of response rates in these individuals. And really, when this study came out, became the first regimen to really target this generally poor prognosis group of patients and provide newfound benefits that we were not able to see before with chemotherapy using one of these targeted therapies alone rather than in a doublet. New light's also been shed in the last several years on colorectal cancer that primarily presents as metastatic peritoneal disease. We know these individuals have the poorest prognosis among patients with colon cancer and only probably represent about 10% or so of new metastatic colorectal cancer diagnoses. But there's been lingering questions for years about whether cytoreduction, also sometimes called peritoneal stripping, either alone or followed by heated intraperitoneal chemotherapy or HEPATIC, which is something that's been used for years in the GYN community for treatment of ovarian cancer. So the question has been, could this also be used as a way to control this local abdominal disease in patients with metastatic colon cancer? We've been doing this in the GI world for a while as well for low-grade mucinous tumors of the appendix, but really there had not been a move or data to support that this should be used in metastatic colon cancer. But the authors of this trial, PRODIGE-7, set out to look at this question. And in this study, they randomized folks with metastatic colon cancer with peritoneal-only disease to surgical cytoreduction or debulking versus the cytoreduction plus this heated intraperitoneal chemotherapy. Excuse me. Interestingly, they found that while outcomes and survival after the cytoreduction part of this were really impressive. The HEPATIC itself didn't actually offer a whole lot of additional benefit. So in my view, this has actually really opened the door to increased use of cytoreduction in patients who present with especially limited metastatic peritoneal disease that is amenable to cytoreduction, and patients that are healthy enough to undergo a procedure like this with a specialized physician who knows how to do a cytoreduction. But clearly from this trial, the patients who were able to do this and have a really good cytoreduction done definitely benefited. Their survival was improved. Whether we'll be able to ever figure out what we need to do to the HEPATIC to make it better so that there's benefit in that part as well, I think we still have to see. Finally, a few words about hepatic arterial infusion pumps, or HAI pumps. This approach to treating metastatic liver cancer, metastatic colon cancer to the liver and liver only, was developed and perfected pretty much in the early 2000s at Memorial Sloan Kettering by Dr. Nancy Kemeny and her colleagues, and really still remains an option for patients who have liver-only metastatic disease and are willing to accept having one of these pumps implanted in the abdomen and plugged into their hepatic artery. This is pretty specialized technology and really requires sort of the expertise in placing these pumps and managing these pumps. But this has slowly become more frequently found at different centers across the country, and there's a slow uptake of acceptance of this kind of technology in the right situation. I think that, again, a big part of this kind of therapy is really selecting patients that are going to benefit from this, who are willing to accept some of the additional risks that having one of these pumps placed, and who understand that the management of these pumps is technical and nuanced, and it really requires a high level of expertise. But I think the data from Sloan Kettering and the Kemeny group have demonstrated that remarkable responses and extended survivals can sometimes be achieved in these patients with the placement of these pumps and the use of FUDR chemotherapy delivered directly to the liver. Finally, a few new areas of research that are under development and that I'm kind of keeping my eye on because they're exciting. One is the EGFR targeted therapy and whether we should be delivering it more of an on and off setting rather than a continuous setting. Development and testing of vaccines for metastatic colorectal cancer, as well as development of vaccines in the colorectal cancer prevention setting for patients with Lynch syndrome. The testing of PARP inhibitors in patients with colon cancer that are deficient in homologous recombination, or HRD, like tumors with BRCA mutations, ATM mutations, and CHEK2 mutations, which once you sort of put all those together is actually a sizable chunk of colon cancers, maybe about 15%. And finally, the efficacy of immunotherapy in the adjuvant setting after resection of MSI-high colon cancer. This is an area that I think is particularly exciting. There's a national trial going on called ATOMIC, which is evaluating this. I think this is particularly obviously really important for Lynch syndrome patients because this could really sort of be a game changer for those Lynch syndrome patients who present with advanced stage colorectal cancer, who are surgically cured by surgery, but who are at risk of recurrence. So I think, hopefully we'll have lots of people joining up for this trial, and we'll get great information from this trial in the coming years as to whether immunotherapy has benefit in the adjuvant setting. And with that, I thank you for your attention.